It is a tremendous privilege for me to be here with you. When someone lives the spirit of palliative care and they pretend to live life intensively, they know that each minute counts. When you are invited to speak about economy, you realize that it is also a privilege to be close to a patient in healthcare systems, organizing and managing systems that will make this turn into a reality. I would not like to talk about the impact, the economic impact, but the impact of palliative care and what is the financial outcome of this. It is very important that you're all here because this is you who are moving the world from the policies, from the management, from your scientific associations and societies, and also from the media. And many of those of you who are here are excellent examples of things that might help in changing the whole situation. I'm here to speak about financial results, and let me start with some of the arguments which are mandatory on our daily lives and those that are applied. Some words of Maria Andrade, who is a politician. I want to live close to very human people who know how to love, who do not consider themselves elected before their time comes, who do not run from their responsibilities, and who only would wish to go in the hands of truth and honesty. Not implementing palliative care is giving their backs to the essence of our human nature, irrespective of our nature and responsibilities. Within this look, we have something that represents humanity. Compassion is on the basis of our social system, on the basis of our economies, and on the basis of our justice, and the balance that we get in providing palliative care. We will see some examples. And this is why healthcare systems are really unsustainable from the economic viewpoint. I know that you have to do magic with your budgets because we are having a social and demographic change which implies the growth of chronic diseases, and we have less and less people being capable of looking after them. So we have a gap between the curative action and the lack of a clear scheme as to how to contribute to the funding of to medium to long term. We need to change the paradigm of health and the funding of health systems because the goal is not curing. The goal is curing and looking after. And this hard balance between your responsibility and what we are capable of achieving is something that places us in this situation to define if it's better to have palliative care or a palliative care expert or an oncologist if there is a child who's dying from cancer. At the end of these comments, I would like to realize that there's no other choice than developing palliative care by the end of our lives. And this should turn into the foundation of this whole system because we will be puppets of a mercantile system which is always leading us where they want to lead us through. And we have the real possibility of changing things here. This is the circle of Dr. Julian Abel. You have to understand this circle. The person is not the person at the center with the community around and the health and social services around. It's social and health services on the basis for the service of the community. And we have to think about each person that lives the earth. And this is a big change that we need to implement. Why is this like this? These were the first studies of the Medicare system in the U.S. when you know that it's by the end of life when most of the costs are accumulated. And this is normal. This is when we are most ill. And we know that 40% of the health expenditures that a person generates to the system is placed in the long and last part of this curve. And we know that the This is the cost of someone who's at the ICU without palliative care. Dr. Brugger shows how this decreases these costs. This is not Medicare. This is figures that belong with Latin America. These are figures in Colombia of some of the insurance companies with public funding. You see how this cost goes up by the end of life. This is the last months of suffering, of uncontrolled symptoms, and healthcare systems providing services one after the other. As you can see here, it's not about reducing resources, but providing more with high added value and less costs. When we took a look at this study on 25,000 terminal patients at the different regions of the country, and by different causes, ultimately the cost of care is always increasing. The cost studies in the US showed this. It isn't sustainable to provide care for patients in a terminally ill situation without palliative care. It isn't sustainable. The health and social system in Canada isn't sustainable. Same thing happens in Ireland and in the UK. It isn't sustainable to receive healthcare without connecting the healthcare system and the social system. Because like the health costs increase, the social costs increase as well. As the disease of Don Jose increases, there's disability, and together with their disability, there's dependency on receiving the right care. And this is why we need a system that will be capable of looking after these people in their basic needs. At the same time, the healthcare system is looking after disease and health. And this is why the systems need to be integrated. This is the look that we need to have. We have this big task of turning around the whole paradigm. We have a system, as Dr. Lima mentioned before, like also she's shown the lack of balance, the Lancet Commission report. We need to change this towards a model that will be value-based. We have to go from the payment for a service, even in those countries which have palliative care. We need programs. We have to be capable of understanding what happens, because this is not just a matter of cost effectiveness. This is an opportunity cost issue. If we do not do this in our system, they will go into the abyss. Going from activity-based payment, vertical payment, to horizontal systems, health programs. And I will share the example of the Lucy project with you. Some colleagues invited us to Colombia to help change the situation there. And there were important priorities that were already tabled. There was legislation, fantastic experts, professionals. There was a certain level of education, but we wanted more. And however, there was a scarcity of these kind of programs. Now, reading an article by Dr. De Lima on Lucy, who's a friend of hers who died years before without the necessary resources, I just called to say it would be nice to give it a try in Colombia. She said it won't be easy. Why don't we call it Lucy Project in the honor of your friend? And she said, okay. And this gives us strength. 100,000 persons per year needed palliative care at the beginning. There was a scarcity of resources, very good resources on palliative care, but they were just a few. And we needed a new way of governing. There was a good political framework, but we needed to foster a national strategy, as the one there is in Panama right now, which started to change the whole situation. There was training, but we needed to promote it even more. There was awareness, but the people still died without knowing what it was like to be close to their relatives, to their friends. One thing is knowing, the other thing is willing to. And this is not a necessary implication of the healthcare systems, but the society at large. But especially, there's something that was needed, which is the second part, which is the increase in access. Because what was already missing was a management model. So they still pay by activity, and all of this is represented as an expenditure and not an investment. This is not expenditure. This is the most profitable investment that we can have in our systems. And we use the new PALEX methodology. It's the methodology of the New Health Foundation. You can use any methodology, and this has been multiplied by 11. The satisfaction has been increased by 95%. The burnout of professionals has been reduced by 30%. Cost reduction, 10 to 20%. It's now a dream which came into a reality. There's 7 insurance companies in Colombia that are doing this. So when we speak the same language, we start adding numbers, and over 30,000 patients who are dying per year. What we see here is the figures which were mentioned by Dr. Knoll. We mentioned that around 63% of them needed palliative care. This is a reality. In your countries where 200,000 people are dying, 100,000 need palliative care. 100,000, and maybe there's no more than 10,000 who are receiving this. And this is more than half of the people dying and spending money. What happens when you develop palliative care? In effectiveness and satisfaction terms as a clinical outcome, we are capable of alleviating pain, even better than without palliative care. We are capable of increasing the well-being feeling even by the end of our lives. We are capable of having clinical evidence that we are improving the suffering, the dyspnea, and that we are alleviating this feeling of loneliness as well. So when we apply palliative care, we are capable of improving the clinical situation of our patients. And what is the consequence of all this? The consequence, it's an economic consequence. It's not a cost, it's a consequence. As you see here, in some of the palliative care projects, this is expressed into millions of pesos. But the important thing here is we take a look at the final number. In the last 3 months of life, 7 million pesos are being spent, while outside the program it's 20 million pesos. This is efficiency. By providing palliative care, we can better use our resources. And in this way, it reduces the median of the cost in the last quarter of their lives. This is other information. This belongs to one of the insurance companies who has implemented this program. And this data is brutal. This means that for a health manager, not implementing palliative care is negligence. This is a total savings in one of the projects, 5 billion pesos in the first year of the project. Take a look at this. The baseline is outside program, and with the program is with the palliative care. The average cost, when it is prepaid, it reduces by 37%, but in the last month, the drop is 1/60th% per patient of the cost without palliative care. When this happens in public insurance, it goes down by 44% per person and per month, and this is what we see here. This is the result over thousands of patients, and it has been replicated in different organizations. In blue, you take a look at the costs until the end of life without palliative care. Those patients who, even in that same company, that same institution, did not achieve to get to the palliative care unit, and this is why there's this replication equal to the baseline. because in orange you can see the cost line of those patients who were lucky enough to receiving the best clinical care by a palliative care program. The difference is the difference between the blue and orange curves, and this happens at the national scope, and this happens in each one of the regions for private insurance and for public insurance. Not implementing palliative care is negligence. And someone who might think that what we do is providing less services, this proves otherwise. In orange, you see what's the drop in the costs, as the graph in the left shows, but you can see what happens in the number of services. We are providing more service, more healthcare service with more quality, with a higher quality. This is value in health. So therefore, palliative care is the best evidence of what value in health means in the healthcare system at the international scope. If you want more evidence, I show you more evidence. On top, this is patients who are outside, off schedule. This is off schedule at the national scope, at the private scope, and at the public scope. The cost of someone in the last month of life was 11 million pesos without palliative care. With palliative care is 5.1. So before it was 18 million, and now it's 7 million in the palliative care system. When it is off palliative care, it's 8 million, and with palliative care is 4 million pesos. And as you can see here, this ratio, it goes from 80% to 50%. It's brutal, really brutal. When this is seen as concerns the different insurance companies, you can take a look at the numbers. 11 to 5, 8 to 4, 11 to 4. And the hospital costs decrease even more. And this is what you see in this graph. In blue, you see the hospital spending. In orange, this is the hospital costs receiving palliative care. And this is not just because. This is because they start to see some bars which are taller in orange. This is not magic. You are changing one intervention for another. Someone made the decision to say, I'm doing this differently because I can change my future. When this is seen differently, take a look again at the difference between the blue bars and the orange bars. This is dollar by dollar. This is not estimations. This is outcomes. This is measured from a PIG and a balance and from follow-up. And see what happens. 22% of opioids off treatment, off system. When there's a palliative care system, they receive 80%. So this means to increase healthcare services. There's a reduction in hospitalization. There's an increase in household hospitalization. You need to know where you're putting your money into, because your money has to yield, and this is our responsibility as responsibles of healthcare. And we might not do this if we do not understand that the life of Don Jose is off and that it requires to work, as also de Lima said, with the social aspect being considered and the community being considered. The only way of being able to develop a stable model is understanding that Don Jose's life is not part of this consultation. We need the best experts, the best subcutaneous infusers, but we need to have social services capable of looking after Don Jose and looking for someone and working with this person who start cutting their hair to manufacture wigs for those people who do not have money to cost a wig when they are going through chemotherapy. We need to understand what are our human priorities. We need, as Mario Andrade said, we need to understand that we're here because of dignity and because we need to know who we are. We need to know what our implications are. Be you part of a pharmaceutical company, or you as a part of the government, or just you as a person. We need to be a nice human. And we have to look for this motivation, knowing that our investments have to be used to change. Because we can do it. One of our objectives is to be compassionate. Compassionate means mobilizing to help those who are suffering, means to be capable of identifying every day who are underserved. Our main flaw here is coverage. We have to be very brave to wake up and find out who we are not serving, but to take a closer look at the mirror and know who is not being served. Where's the gap? Who are those that I could have reached? And when you find this, your life changes because this is a common identity. This is what unites us as clinicians, as politicians, managers, as journalists. The compassionate cities, this is not a new movement, compassionate communities. This means that there's a community promoter who's working on healthcare, social, and community services. And when they go home, they don't have anyone to look after them. So they will enter hospital again with the economic impact that we saw. However, when they work from a community viewpoint, then we spend first day having Doña Luisa looking after Don Jose, and in 2 weeks, there's 9 caregivers looking after Don Jose. If Don Jose does not have anyone to look him after, he goes to the hospital. So compassionate communities is not the outcome of romanticism, is the re-encounter of the community with itself, to see what we are doing here as human beings and to be very aware, being humble and aware of healthcare services, understanding that we cannot stay in our hospital system to look for others' lives. And as managers, we need to ask for money for others so that as colleagues, we can recover this level of health care givers that is needed. We are working, and we have sometimes less brothers in our families. What's the economy of this world saying is that it is sinking because solidarity took a walk out and never came back. This requires involvement. We need more evidence. And the evidence is here. What we need is to work hard in each workshop, every day, every week, knowing what we are doing. This is where we are now. In this silence. Maybe we are lost among so myriads of floors of disconnected souls. Or maybe being extraordinarily aware of what we do, paying attention to each detail. We can stay here being anonymous, being labile, without changing anything around us. Or maybe we now should realize that it's enough of so many lies and that it is worthwhile. And that this is not something alien to us, alien to our own lives. We are part of this humankind where we share. It's about sharing, it's about understanding that irrespective of where we are, we have, as Mario Andrade said, hurry in our souls. This poem, beautiful poem, ended with a magic phrase here. You go through the clinic and management just a while in the history of mankind, and we can change things and can help in changing. Mario Andrade ended his poem by saying, and in the end of all, we know that we all have 2 lives. 2. And the second life is the one that ends when we realize that we only have one.